right, let's get back to the studio. All right, everybody. So again, Tim Vermillion here from EMDR News, and I try to get here on weekdays to explore things related to EMDR, trauma, veterans, and clinician-focused work in general. Today we have a couple things that we're going to talk about. One thing is psychedelics and the VA, and the other is going to be on clustering, which I believe is in the EMDR News site. Generally, what we want to do is to kind of talk about those things that are in the EMDR News site, so that we can get some other ideas and thoughts, and just kind of uh, hear what's going on when we want to explore that. Okay, so just a reminder as we start the field signal aspect of things, the conferences are coming up. We have the EMDRIA conference in the middle of August down in or over in Anaheim, California. It's right next to Disneyland, so bring your family. The ISTSS conference meeting, however you want to discuss that, that will be in September, and that is going to be in San Antonio near the Riverwalk. So if you've been to the Riverwalk, it's great. As a veteran military person who is in the medical field, San Antonio is where the AMED Center and School is, and so Fort Sam, Fort Bliss, all those places down there are places that we have been if we're in the medical field generally. So I love it down there. The Riverwalk is awesome. It's basically a little canal that goes through the center of San Antonio, and there's restaurants and bars and different things on either side of the canal. You can also take a little boat ride in the canal. One end is a mall, so there's a mall there, and then you can walk a very short walk from the canal, from the river walk from that mall to the Alamo. And if you haven't seen the Alamo, it might surprise you how small it is, but it surprised me. But I've been there a couple of times throughout my life, as I've lived down there in Texas before as well. But it's small, it's nice. You can go in there and check things out and see some of the relics from that time and that period. Um, but and it's weird because it's right in the middle of a city, and you look across the street and there are buildings, skyscrapers. So it's a little tiny mission style church thing, and then you turn around and there's a giant city behind you. So pretty crazy when you think about it. Now, yeah, I'm gonna go down there for the ISTSS 2, so I'll be down there for that. And then EMDR Humanitarian Assistance Program, their conference is going to be in South Carolina, I think. I said it the same way last time, but it'll be in one of the Carolinas. I believe it's South Carolina, and that'll be in October. So we're pretty set for conferences moving forward, and hopefully I'll see you in some of those areas. And if you see me, say hello. There are some other things that have been coming up in the news and whatnot in terms of EMDR and the different things, different grants that are out there. So if you want to take a look at the field signals, if it's not updated yet today, it'll be updated with the new stuff that's been going on. But right now, if it hasn't been updated, there's something about equine therapy in there from a grant that was provided to do equilateral equine therapy, which is working with horses and EMDR. I do have a colleague, supervisee, consultee person that I've been working with for a very long time, and um, and that's one of the things that she does is the equilateral therapy. So it's a good therapy. People seem to benefit, and having those uh, majestic creatures, those horses, be part of the process is really fulfilling for a lot of people. I think MGM might also have an equilateral therapy speaker next month as well. So if you're going to be there and you're interested in that, then you might want to sign up for it. I debated doing a um, like who's who in terms of who's coming to the MGM conference, but I might still do that. I might do that here as well. So just some ideas and thoughts that I might get into, kind of get people excited about it. You get your CEUs, you get an understanding of what's happening in the field from EMDRIA, they're EMDR International Association, some of the things that they're doing, research, and just making sure that the quality of EMDR is the best that we can make sure that if somebody's EMDRIA certified, that that they're giving good quality EMDR. So they're really working hard over there. I appreciate all the work that they do. Um, so yeah, I might do a session on who's going to be there. What are their presentations, and kind of just exploring those a little bit. I remember in the MGS Summit a couple of years ago, they had the a psychedelic um, and EMDR presentation, and which is fitting because we have the VA and the HHS getting together to work out some studies on working with psychedelics within the context of PTSD and post-traumatic stress treatment. It's not specific to EMDR, but again, psychedelics are being used. We know that there is some research out there, and then some practitioners out there that are working with psychedelics and exploring it. I think it was ketamine, actually, a ketamine process of somebody doing EMDR and ketamine. The psychedelic study is supposed to be up today, so if it's not up yet again, just wait for it. It should be popping up on EMDR News, and it touches on the VA HHS site uh, study situation, but also gets into um, the EMDR aspect of things, and what are some of the things that we've seen as far as EMDR and psychedelics. So that's kind of what's going on in terms of some of the research that's out there. Again, anything that I'm missing, we might pick up with on Monday. Tomorrow, again, not going to be here. Going to go, play military, play army, go do some stuff. So that's what I'll be. Today, I want to talk about. I was debating clustering versus doing some discussion on the EMDR continuum. Um, because they're both very important when we are talking about complex clients. And I don't really have anything written within the system, within the EMDR News website yet on um, the EMDR continuum. I don't the EMDR continuum. Why this is important is because people aren't always ready to do full EMDR, right? And so we have three things that we can look at least to start with, and that's EMD, or movement desensitization. We have EMD, the restricted version, restricted EMD, or as some people like to call it, EMD small r. And then we have our full standard protocol, EMDR, right? So those are the three things that we would look at in terms of the EMDR processing continuum. And based on your clinical judgment, you might find yourself deciding to be in any of these areas in any given time with your clients. They're all very useful. And for our complex clients, these are the key to getting them to move through the material that you need to get them to move through in a way that can be titrated and more easily digested. So let's start with EMD. Now, EMD is the first thing that Dr. Francine Shapiro came up with when she was doing her early work. And EMD is basically a desensitization protocol. Right? It doesn't necessarily expect that you're going to have that R part, the reprocessing. It doesn't expect that your mind's going to go and make connections to various things, right? We haven't really got to the AIP part of the work when we just settle in on EMD, right? So with EMD, we can take a whole memory, but usually we're taking a part of it, a part of a memory, an image, a negative cognition, a sensation, an emotion. We usually we're taking a piece of it, and then we're going to kind of hyper focus on it. For those that say, hey, EMDR is prolonged exposure, this is the closest piece that I would say, yeah, well, maybe, EMD seems a little bit prolonged exposure, right? Because instead of EMDR, where we're having them touch on the memory and then bounce around to whatever their brain wants to pull in. For EMD, we're going back to that little piece, that segment over and over again. They don't have to say what's happening in the segment. There's a lot of differences in terms of EMD and prolonged exposure. But what we do have is that we keep coming back to that exposure component. We keep coming back to that image or that smell or that thought. So for those that hold that above us as saying, hey, the EMD is just something else and different with different words behind it, different letters in front of it. Um, the EMD would be the closer one, but it's still different. So with EMD, for those that know the full EMDR process, the full EMDR process is let your mind go wherever it wants to. There's no supposed to's in the process. You're free associating, right? If you think about psychodynamic therapy or the Freudian type where you're laying on a couch and the person's like, just go, just talk. Just, and the person, the psychoanalyst doesn't say much, except, uh-huh, right? And the person is just divulging whatever's coming up to them in a given moment. It's kind of like free association. That's similar to what we're doing when we say, okay, let it go, right? And they let their mind, we fire up their memory, but then we just say, okay, let your mind go wherever it wants to go. It doesn't have to stick with the memory. And that's why it's different per se than prolonged exposure is we're not having them do that. We don't want them to do that necessarily. It's whatever the brain wants to do. So with EMD, we are sticking with it. With EMDR, we have our distraction can, go for a long time, right? However many passes or whatever bilateral stimulation that you're using, um, however long that's going to be, however many passes, however many taps you're going to do is usually longer for full EMDR. For EMD, you're given 12 to 20, give or take. You can expand or contract them depending on your client's presentation. But you're doing the work with EMD in order to help desensitize, but not cause them to start to reprocess. So that's why we shorten the sets, because if we add sets, is more add passes rather in a set, it's more likely that they're going to start to connect and associate with other things. But right now we're just trying to constrict it and try to desensitize, get that disturbance, whatever it is, to come from a higher point when you bring up that picture or that thought or that other slice of memory and bring that down. I say bring that down because not necessarily will it get to a zero, like a no disturbance or neutral. And that's okay, right? If we can get something that was a 9 or an 8 down to a 4 or a 6, right? And we're doing some good work there. Um, so with EMD, again, it's slower, or not slower, but lower reps in terms of the passes that you're doing. Usually we're focusing on an aspect of the memory, not necessarily the whole memory. And when we do EMD, we come back to that target all the time, right? Now, with full EMDR, once we set the stage in phase 3 and say, okay, let your mind go wherever it wants to go, we don't come back to the memory very often. We come back to the memory when certain things start to play out, right? When the person that is going through the processing starts to have neutral experiences, things aren't changing, whatever it might be, then we would come back to the target. And in this case, in full EMDR, we don't say, go back to a specific piece of the memory. We just say, go back to the memory or go back to the target. Target and memory, we can use interchangeably in this moment, right? So we're not saying go back to that image. We don't want to tell them where to go in full EMDR because their brain might move to something else, and that's perfectly fine, right? And we want them to process and continue moving forward. The other aspect of EMD and EMDR, so EMD, we're going to that back to that specific piece of the memory. So when you go back to that image, when you go back to that sound, right, we keep coming back to that, right? So also we are checking our disturbance more often. In the old days, the checking of the disturbance was done basically um, every time. So we would do the BLS and it would be checked every single time that we would do do the passes, go back. When you bring up the image, what's coming up for you, right? What's the SUD now, right? And the SUD is the subjective unit of disturbance, or the number on a scale from 0 to 10 that is letting us know how disturbing something is subjectively to the person. So we do the BLS and the bilateral stimulation, but now we don't check it every time. We check it much more occasionally, or yeah, much more often than we would with full EMDR, but it's not every single time. One of the reasons is because we don't necessarily want them to start giving us the answer just because they don't want to hear us ask the question again, right? We don't want to have that be part of the work that we're doing. So that's kind of EMD in a nutshell, right? We are trying to take a piece of the memory and desensitize it, not necessarily to a zero, but from wherever it is that's a pretty high disturbance to something that's pretty low, and then move on to full EMDR if we can. Now, we still do phase five within the EMD context, right? We're still going to do that. Um, we're going to try to install the positive cognition, whatever it might be. We don't necessarily do the body scan for EMD. There's a lot of work that we still need to do, and sometimes we leave out the body scan. But the positive cognition we can look at in two ways for EMD as well. One way we can say that the positive cognition is exactly what we would expect it to be. What would you like to believe about yourself instead when you're thinking about this little slice of the memory, right? Whatever it might be, the image, cognition, whatever. However, and that might not get to a seven, like completely true, right? Because of the work we're doing, they might have a lot of work to do before that can be a completely true. We might have to do the full EMDR processing on the full memory before we can say that whatever that little segment is completely true. It doesn't mean that we don't try. We try to get it to a completely true, but in EMD, we get it to as high as it's going to get, right? So we get it to a certain number. If it sticks at that number, great, and we can move on to full EMDR or restricted EMDR. Um, what else can I say about that? There's something else that we're missing there, and I just want to kind of bring it up, right? And that is uh, we can, if it is a positive experience for them, if we're able to bring down the disturbance to a certain level, raise the positive cognition, that positive thought to a certain level, and it's not a zero, maybe it's not a seven. So what we could though do is to say, okay, well, what was it like for you to experience that feeling of having been able to um, have that disturbance go down, right? And so they might be able to recognize that and say, I don't have to suffer, whatever the thought is about that idea, that they can bring the suffering down could be the positive cognition that we work on, that we rely on, instead of the positive cognition, which is generally the opposite of the negative cognition. And this is mostly just for EMD that we're talking about, mind you. We can give them that ability, that kudos, that resource of saying, hey, I did good here. You can do both too. You can do EMD, try to get that positive cognition up, and then do a resource, like a resource development installation, and saying, well, what does this mean about you as a person that you're able to bring that disturbance from an 8 to a 4? What does it mean for you about this process? Right. And we can build that in as a resource and see if there's something there that we can strengthen and have them be able to use as they move forward to other parts of the memory or the memory in general. So that's EMD, and we can slice the memory as thin as possible if we want to, right? So if we are talking about an assault memory, and they're like, "Well, I don't want to go there. It's just too tough to even think about." And okay, I can appreciate that. So what if we slice that up? What if we say, "Okay, I don't want you to think about the whole memory. I just want you to think about like the just the worst part. What would the worst part be? Seeing them come at me, right? That first part of seeing them come at me. Okay." And when you think about that worst part of them coming at you, what's the worst part of that, right? And we start to slice it thinner and thinner and thinner until we say, okay, and what's the worst part of that? And I said that look in their eyes. Okay, so let's take that. Let's just take that little piece, that look in their eyes, and work with that, right? I don't want you to think about anything else, just the look in their eyes. So when you bring up that memory and just the look in their eyes, right? And we start to move through EMD with just the look in their eyes. We can take a half a step back after we do that work, and maybe if it was the look on their face or the way their mouth was, whatever it might be, that other slice, if that has some salience left to it, because sometimes after we do EMD, you'll notice that other parts of the memory are also coming down. They're also having a reduction in disturbance. So we bring that down, and at some point, either that first piece that we worked on, or maybe another piece or two that we work on it with EMD, at some point we say, okay, let's try the full memory. All right. And we go back to full EMDR to reprocess the memory. If we're lucky and the process has been working as well as we could hope, then you might notice that the disturbance, the subjective unit of disturbance, the SUD, is already getting down lower, like it's close to a zero. Could be a zero sometimes, but in any case, that's when you're going to start doing your full EMDR. Now, EMDR restricted is when we want them to reprocess a little bit, but within the context of the memory that we're working on. So it's not going back to the same image over and over again. And if they go to the image and the thought that they had and the sensation they had, whatever it might be, some other things that happens around that specific memory, right? All of that is good. But if they start to drift into another memory, especially one that has a higher salience and has a lot of energy to it, and starts kind of sucking them away from the current memory and only thinking about this other traumatic piece that is really traumatic and really encompassing of their attention. All right. And then we might say, okay, let's put that on a shelf. Let's put that away for now. We'll come back to it. We'll put it on our list of memories if it's not already there. But is it okay for you if we go back and look at the memory that we started with today, right? And so that's restricting the memory to the specific context, restricting the EMDR to the specific context of the memory that you started on. So when they drift to other memories, you politely, calmly put that memory away, come back to the memory that we're working on. Right. So that helps you focus and constrict the memory to a specific aspect of or the work to a specific memory or aspect of the memory that we need to pay attention to. A lot of times when people are starting to get better, or that memory that they're working on, I should say, starts to have a reduction in disturbance, that's what will happen is their brain will stop thinking about it, right? There's other things to ponder, other aspects of the memory that or other aspects of the person's experience that might pull their attention away. And so we want to continue to work on the memory that we started with, because once we get that one done, we can move on, right? But we want to put these memories down as a 0, 7 clear, right? No disturbance. Positive cognition or the positive thought is high. A VOC of 7, a validity of cognition of a 7 out of 7, very true. And no body sensations when you think about the memory, right? That's what we want to get to. So we have to keep coming back to that one memory until we're sure that that's the case, that's where we are. All right. And then full EMDR is full EMDR. So restricted EMDR, you can restrict passes a little bit. You can have them be less so that we don't have as much association. And that again is going to be in communication with your client. And I'm not talking about just verbal, I'm just talking about body language. So if they start to move and start to bring up more associations, maybe the next set is going to be less, right? Less BLS, bilateral stimulation. All right. And then full EMDR. So uh, I'm not going to go too deeply into that, but full EMDR is what it is. You go for as long as the client needs to go before there's some apparent change in terms of the work that they're doing, and then you bring it back and check the target, and you keep doing that process until the target, the memory itself that you're working on, is desensitized, and there's some positive aspects that are adaptive resolutions that come along with it. And then we kind of move forward from there once we note that the body scan is also clear and not holding any more of that memory. I think last time we talked about how cognitive interweaves yesterday we talked a lot about cognitive interviews and the idea that we'll always check our work. So once we get through this difficult memory, there's multiple times where we're going to be attending to it just to make sure that it is maintained its um, desensitized status. EMD restricted, again, just sometimes it's lower in terms of BLS. We're not going back to the target all the time like you are with EMD. It's just when we start drifting into other memories that might suck the energy out of the one that you're working on, might take all the attention away and stop you basically from reprocessing what you want to be reprocessing. All right, so that's the EMDR continuum, right? That's EMD where you're doing just a slice to EMDR restricted where you're kind of sticking with the memory and any other things that are coming up, we might just put on a container, put on the shelf, come back to the memory, and then full EMDR where you're allowing your mind to jump around to other memories, to other experiences. Right? Again, the goal is to bring up some of that adaptive material, some adaptive resolution, and also to desensitize the material. When we do all of this, we expect change being a byproduct of the reprocessing that we're doing. So what that means is that when we are working on a past memory, um, hold on a second, when we are working on a past memory, that the um, memory gets desensitized, but that adaptive resolution, those lessons that you learned, those things that came up while you were doing that work, start to affect other things, right? Other memories sometimes. So that's why we can hope for generalization across the board. So when you're working on one memory, it might have an effect on the other memories that you haven't even touched yet. But also in the present day, right? So if you learn something about yourself that changes your behavior, then when you go and start to interact with other people in social settings, at work, within your family, you might have a different experience. And that is the change. That's the byproduct of the reprocessing that we're doing. Pretty cool, right? I think so. Um, so that is a lot about, I mean, right now I don't have any questions. Yeah, any questions right now that are going on in the stream here? Remember, you can always ask questions, and I'll try to answer them as best as I can on here. Any questions that I don't get to, I might be able to put on the site so that you can go look and check on those sites as well, on those questions as well. So if you do have something that you really want me to kind of touch on, then let me know, and then Monday, Tuesday next week, we'll try to get that working for you, get that in there for you. I'm excited. I'm enjoying this, working with you all. The podcasts, I want to bring a moment to talk about those. The podcasts, for the individual things, I kind of took a pause on that for a second. I'm going to restart them because I even listen to them, listen to my own podcast. But, that I just want to improve the quality a little bit in terms of some of the language I use, just because I put in some of those little more dramatic pauses and stuff like that within the context of doing those, just so I can keep attention. But I don't know if it's working. I think it might be. I don't like the way that sounds. In other words, so I'm just going to try a different route in terms of getting those podcasts up. It is mostly, like red, so I don't have as many ums or all those things. It's easier to listen to. So here is live. You get to hear all the nitty gritty in terms of things that get stuck on, the pauses, etc. But there, it's a little more polished. Also, you might notice that when these things start getting put up onto the Entria Live Desk site excuse me, the EMDR News Live Desk site, within the context of EMDR News, it's going to be a little more polished up there too. So here on Facebook, LinkedIn, etc., is really where you're going to just be able to see the live piece for a little while, and then it'll be polished up a little bit. Okay. Um, Anything else that we can briefly touch on before we move along? We touched on the research thing briefly, the new rules that the HSS and the VA are trying to hammer out so that they can do some psychedelic studies. So that was the piece there. The practice piece is the EMDR continuum, and the field piece is the equilateral therapy and the things that are coming up as well. So those are the three things that I'm generally going to try and get to: practice, research, and what we're watching, what the field is doing on some level. I'll also let you know if I have any resources within the system, new handouts or anything. That reminds me. Um, we still do have our BLS tool, right? So that's we call it the Wombat BLS tool, Working Memory Online Bilateral Attention Tool. That's a mouthful, but if you want to get involved in that, it's a free bilateral stimulation tool, and it can only improve. So if you let me know what is needed, I can help. I can improve that. Again, it's free, so it makes it so that we have less ability to save things, right? Once you start saving things, then it might cost more because we have to figure out where to store those things, and those things, that storage, um, tends to end up costing money. So we'll explore that. Okay, so this is Doc V from EMDR News, and thank you for coming. And I'm hoping that we will continue to see you and continue to explore mental health, therapy, veterans, and EMDR together as we move forward. You can get me on info at EMDR News. You can find me there. You can send out a message there. You can also reach out on Facebook at the EMDR News site there, Twitter, X, and even Instagram. Yeah, EMDR News is everywhere at the moment, so feel free and come find us and talk to us wherever you uh, are, wherever you find yourself. Have a great day, and